Welcome to NeuroNoodle's Neurofeedback and Neuropsychology podcast featuring tech legend Jay Gunkelman. He is the man who has read over 500,000 brain scans. Our goal is to provide information and promote options for better mental health. The NeuroNoodle podcast is supported by listeners and viewers just like you. And a special thanks to our gold and silver supporters. Earn up to 16 CEU hours by attending Applied Neurosciences NeuroGuide Workshop December 10th and 11th in Madeira Beach, Florida. It's led by none other than Dr. Robert Thatcher himself. There are two ways you can attend: online or in person with the link appliedneuroscience.com/attend-ng-workshops. And if you sign up now, you can join Dr. Robert Thatcher at his house for a pre-course get-together December 9th. It's going to be a blast. What a better way to enjoy winter by being in Madeira Beach, Florida, and earning up to 16 CEU hours. Sign up now at appliedneuroscience.com/attend-ng-workshops. Mindmedia.com. Get the latest EEG and neurofeedback technology from mindmedia.com. Their semi-dry sensor cap is a wonder to see, and their EEG amplifiers have been trusted in the field for decades. Their neurofeedback and qeeg courses will get you up to speed in no time. Visit mindmedia.com now. Welcome to Alpha Waves Part 2. Alpha in a Can.
These are, again, bidirectional, unidirectional, and then resting state all by itself. If you read the paper, they have not only alpha but also beta in these locations, and they talk about the directionality, again, bidirectional, and this is unidirectional. So, the default mode resting state network is your alpha network. If you're going to be training alpha, like the alpha theta state, alpha is a really good thing to train for some people because the low voltage fast person doesn't have alpha and they need it. That they'll like to consume alcohol to slow down their too fast a background that's not synchronized so they can make alpha. And the alpha theta style training will give them that alpha without the consumption of anything. So it's important to be able to train it. And if you're training it, PZ is a great spot because it's your default mode dominant hub. Some people train at 0102, which is just vision. It's your primary visual area. It's not sensory integration. It's just primary visual. Now, there's a lot of mixed opinions as to where to train your alpha theta. I would point to the neurophysiological basis of the default mode network and suggest that PZ is really the spot. So we've seen that alpha turns on and off perception and packets it and orchestrates the processing through the brain. Perception is turned on when assessment is turned off. Try to listen to somebody and speak at the same time. It's not going to work very well. You're either going to perceive or express. They don't work well together. So the brain flip-flops back and forth between them. So let's look at some EEG that has some background in it. The background rhythm is alpha. But if you're only a month old, what's your background look like? Is it in the alpha band? What is it? Well, let's pop this one open. Here's a 1-month-old, a resting baby, a peacefully resting baby. Look at the background activity. This is 1 second long, 1, 2.5, almost 3. This is delta activity. Their background rhythm is delta, not alpha. It's the rhythm at the back of the head. Now, neurologically, people don't say alpha is 8 to 12. Now, if you're in the neurofeedback world, you should probably answer 8 to 12 on an exam if somebody asks you what alpha is. But neurologically, it's the rhythm at the back of the head that attenuates with sensory stimulation. So it could be as slow as 3 or 4 and as fast as 15, 16 before it desynchronizes. 8 to 12 is the average for most adults and kids that are into their developmental trajectory ways. 6, 7 years old on, you expect alpha to kind of be in the alpha band. But at age 1 month, your background rhythm isn't in the alpha band. It's basically in the delta band. We can scroll through this EEG, and in between the little moments where this little tyke is holding still, things go a little quiet, but there's no 10 hertz alpha. Some of it gets a little faster, 1, 2, you can project a 3, 4, maybe bumping into the lower theta frequencies, but there's no 10 hertz alpha. Little electrode pops and little movements moving some electrodes. But you can see how dramatically slow we have this 1-month-old baby. In fact, in order to interpret EEGs, a neurologist has got the license to write the report. But if you want to get good at EEG and you pass a board exam on EEG, there's an electroencephalography board you can take. But it's for adults. There's a pediatric board that's a separate board examination for people who want to look at pediatric EEGs. But there's another one for neonates, for very, very young kids. And that's a separate board exam entirely. There are patterns that look highly abnormal in very, very young kids, especially premature kids. And you don't want to be interpreting that unless you have experience in that area, because you can make a big mistake. We had a neurologist who was, young and not as experienced, and he looked at an EEG on a premature baby that had been done in our lab, and it was stacked in with the rest of the EEGs that were coming in. And he looked at it and said, "Oh my goodness, this baby's going to die." The EEG had big bursts and then went sort of flat, and then a big burst and then sort of flat, like burst suppression, which is something that happens just before you die. But if you're premature, it's something that can be seen in a newborn that's premature. It's called trace alternante, which is a French description. It was originally identified by Henri Gastaut. Again, the same French gentleman who dismissed Sterman's SMR as just being mute. And Lennox-Gastaut, a form of epilepsy, Gastaut's an important guy, as Lennox was as well, back in the very beginning. Lennox was Harvard, and Gastaut was in France, in Paris. So that's the 1-month-old. Let's look at a 2-year-old. And here's a 2-year-old. You can see it's a little faster than the 1-year-old was. Some of the background rhythm isn't all the way down in the delta band. There's some that move up a little faster. And you can see 1, 2, 3, 4.5 or so. Again, it's not up into the 8 to 12 definition, but there are only 2. By age 3, your alpha should bump into the 8 hertz rhythm, but it could be 6, 7, 8. The peak doesn't have to be centered into the alpha band or dominant at 8. But at age 3, you should bump into 8 as part of your background spectral peak. Again, you could be slow. Some kids at age 3 actually have alpha slipped up into the alpha band nicely, but those are not as common as the ones who are slightly slower. By age 5, 6, you should be largely into the alpha band. You can still have a tail sticking to the theta band. At age 6, 7, where most of the databases start, you basically start to have alpha that meets the traditional definition that you expect in the examinations when you're trying to get certified in neurofeedback, the 8 to 12 answer. So here we have a 2-year-old, and this 2-year-old EEG actually has some sharp paroxysms up front that aren't just eye movement. This fell into the normal category with a database that goes down to very, very young ages. But unfortunately, the sharp transient paroxysms up front that aren't eye movement were declared normal, but it's actually an early form that you can see in epilepsy. So this is slightly abnormal. The background rhythms are age appropriate. And again, you can see some of this is almost getting into the alpha band. A cycle and a half didn't quite fit. This is probably a 6-7 at the beginning of that second. It slows down in the second half. So a 2-year-old, again, excessively slow, some sharp, slow content that isn't fully normal. Let's look at a normal adult.
Jay, quick question. Why did we pick 1 month and 2 years? Any reason?
I just had those easily available.
Got it. Okay.
I mean, at 1 month, you're very immature, and you don't have any chance of having anything even close to the alpha band. At age 2, you're still a little slow to expect normal alpha, but you're getting close. Again, age 3, you start to bump into alpha. At age 6-7, you expect alpha to be, reasonably prominent. Now, this is a normal person in Europe, and you can see we have a 50 hertz filter on. I turn it off, you can see those 50 hertz. So it's not in the US. 50 hertz is, this is a European study with 50 hertz. So 1, 2, 3, 4, 5, 6, 7, 8, 9, kind of almost hits 10, 9.5. Now I counted it up front, and this is a person who's ostensibly normal. Alpha starts out in the back, but it anteriorizes during light drowsiness. When you're not as vigilant as you could be, you start to have anterior alpha. The vigilance model basically suggests that this started out fully vigilant, and then they became less vigilant. Now, vigilance isn't the same as arousal, but it's related. If you have a lower arousal level, stage 1 drowsiness, you're going to have a lower vigilance state. But the anteriorizing alpha, this is still awake. You're still in an awake state, but you have anterior alpha. So you're not going to be as able to interact productively with the outside world. So you're a little less vigilant. And as we progress into this in the eyes open EEG, you can see the big eye blinks, but notice that the alpha up front is actually bigger than the alpha at the back on occasion. That's even less vigilant. Start out with alpha at the back, A1 in vigilance modeling terms. A2 alpha's up front, but it's still dominant at the back. A3 alpha's dominant up front, progressively less vigilant. And at some point, you'll have alpha dropouts, which are B1, and that starts to enter into stage 1 drowsiness in a sleep lab interpretation. So this person is going from posterior alpha to anterior alpha. He has a few alpha dropouts, and again, those are vigilance modeling terms. Vigilance modeling people want to look at eyes closed data, but their model fits eyes open circumstances as well. This is the eyes open portion. We're into the eyes closed portion. You don't see the same eye blinks anymore. But again, this is background alpha. And the alpha frequencies in the back of that are in the alpha band. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 hertz. Goldilocks frequency, not too fast, not too slow, just right. Nice 10 hertz alpha. This individual has no primary clinical complaints, and this passes as a normal EEG medically. There's a lot of alpha up front, and again, you could be a little more functional if the frontal lobe didn't have the high coherence. The amount of alpha that stays stable in phase is high coherence. And there's probably a little bit of an affective overlay, but that's awfully common in life, isn't it? Having a little bit of a depressive trait or a little bit of anxiety. So in and out of drowsing, alpha drops out, alpha returns. So this is a normal person, no clinical complaint, but they're not optimized. You could get better function frontally and probably give a little bit of an improvement in mood regulation. During drowsing, and alpha drops out and then slower stuff starts to mix in, but they come back to the alpha state again. The slower stuff that mixes in, again, are the B2 and B3 stages. So, resting state, eyes closed, you expect alpha, you expect it at the back of the head. If you're wide awake, you can see it further forward if you have decreased vigilance or the progression towards drowsiness. Drowsiness has the alpha drop out, which is the reticular nucleus of the thalamus quitting, providing acetylcholine. So the rhythm of alpha quits. And at that point, theta starts to build up as you progress towards deeper stage 1 drowsing. It's not asleep. Stage 2 is sleep. That's a different entity entirely, which has vertex sharp waves and spindles. So the background alpha, again, normal alpha between 8 and 12. We saw 9.5, 10, perfectly normal tuning, a little bit of an anterior presence, but that happened only as we got into the EEG. With the eyes open, the alpha is more prominent at the back, and there's times with the eyes open that you don't really have a lot of alpha. You can desynchronize if you focus a lot. Now, alpha that's present up front, you're not as vigilant, but you're also not as focused. Les Femi, which he's a researcher who's passed, unfortunately, and his partner Susan Shore, they did a very nice job of talking about people that had open focus. If you're focused on something, you block your alpha. But if you are looking at the outside world and you have an open focus without focusing on something, you just take it in, kind of like the absorbing what's coming at you, as opposed to trying to figure it out or dissect it or categorize it or sort it in some fashion. Kind of sponge-like perception, just soaking in what's coming in. You can get that way sitting in front of a TV show, and just kind of soaking it in, as opposed to being focused on analyzing it. You can get that way driving a car, kind of spacing out a little bit, just kind of soaking in what's coming at you. You can still respond. You're not asleep, but you have an open focus. And Les Femi taught open focus to people that needed to be a little less tightly wrapped. And the opening your focus ends up being a good way to kind of let a little bit of your compulsive analysis, go. So you just absorb as opposed to interpret or dissect. So open focus alpha is the A2 or A3 state. You're not drowsy or asleep, the B stages, but you've got anterior alpha. And the widespread alpha that he taught, he actually had his own machine. It had 5 channels. Back then, 5 channels was a lot. Most of the EEG biofeedback stuff was 1 or 2 channels. Tom Kalura had a 1-channel kit that you could make. You got a board with parts, and you could make your own amp. And they had a user group that would make simple Pong kind of software to play with it. But 1 channel was common, 2 was not unheard of, but 5, that was a lot of channels. And he was training at phase sensitive, widespread phase sensitive settings. So he had his own approach, and he worked very well with people that were overly tightly wrapped by training them how to open their focus instead of being kind of over focused. So alpha was trained. It wasn't the only kind of alpha training. Kamiya did alpha training posteriorly. Jim Hart was actually in an experiment in Kamiya's laboratory. And they hooked him up and they put him in the soundproof chamber. They turned on the feedback, which would give him a period of time, and that would give him a score as to how much alpha he made. And they basically all went to lunch and forgot about him. He was in a soundproof chamber, hooked up to this EEG device, learning how to make alpha. He was there for an extended lunch period over 3 hours. Instead of, the 30, 40 minutes worth of the session, and then you kind of unhook them and ask them how it went, So they came back and they opened it. Oh my God, that guy's still in the chamber, So they opened it up and there he is, floating. Now he wasn't floating, but he had the alpha experience. There's actually a learning curve associated with alpha. It was his dissertation in 1974. So this is amplitude and this is time. So what happens is it's a fifth order learning curve. You come in and you're going to be at alpha, and amplitude is going to be at a certain level, and they're going to start to train you, and it's going to go up, and then it's going to go down, and then it's going to go up again, and then it's go up real rapidly. When you walk in for your first session, this guy in a lab coat, there's electricity, there's wires. You start to get flashbacks of old Frankenstein movies of sparks and lightning and whatnot. And, your normal alpha might have been here, but when you walk in for your session, it's suppressed a little bit because of the white coat effect and the novelty and the increased attentional focus. So the first portion of the learning curve is basically habituation. I'm getting used to these weird people with the white lab coats and the beeps and the sounds and the, all the stuff that's going on in the training session. At that point, they try to actively make more active volition. So habituation, active volition, trying hard to relax. It doesn't even make any damn sense. You can't try hard to relax. You've got to let go to relax. You can't knuckle down and relax. So again, habituation, active volition. Eventually they learn, I can't try hard to relax. I kind of give up a little bit. So there's passive volition, and eventually they get it, and there's an exponential increase at the end, and there's actual full acquisition. So habituation, active volition, passive volition, acquisition. A fifth order curve. This is his PhD dissertation. The amount of time required differs depending upon how you were at the beginning. If you're very suppressed, anxious with not much alpha, low voltage fast EEG without much alpha, it takes longer to train it. We actually took this, I helped him look at the data. I came out on a vacation from my lab in North Dakota, hung out at Kamiya's lab, and looked at the data with Jim. So, we looked at this. We also looked at the meditation data. And I took this information back to North Dakota, to the state hospital. We had been doing alpha training in alcoholics, and the learning curve, when you plot the session by session learning curve, you get the same shape, but it took longer because they were working with university students that were basically pretty normal. Well, university students are only pretty normal. You hang out at a university, they're not all like, normal. There's some people like me at the university too, kind of oddball outliers. So, but they were normal-ish, normaloid, passing for normal at a university. We were using this on clinical people at a state hospital who were hospitalized for alcoholism. And they had a low voltage fast EEG and they needed to train alpha. And they would take many, many, many hours. Instead of a 3-4 hour total training time, like a normal person, you can get to this state like Jim did, with an extended period. However, if you have suppressed alpha or clinical issues that are problematic, it's going to take you longer. We found 15 hours, 20 hours of total training time for some of those severe alcoholics who didn't have any alpha to speak of in the first place. They start out down here with no appreciable alpha. And there's no easy habituation to another level because they were just suppressed. So again, depending upon where you start, how much you start with, you get a different amount of total training time. So that's the learning curve, the shape of the fifth order learning curve associated with the acquisition. Now let's get back to the EEG. So we're going to turn off that EEG. I think we've chatted about these. We have to remember that Peniston published his work in 1989 about alpha theta training. And alpha training was done by Kamiya previously. Elmer Green also did alpha style training, but he also was interested in theta, which he found slower content in meditators. So, yeah, they were interested in theta as well. And in 1972, when I started my lab at the state hospital in the alcoholism drug division, a lot of alcoholism, low voltage, fast EEGs, we trained alpha. We found it to be so successful. The normal recidivism rate is really quite high. The people that we trained alpha didn't come back. So we had a very good outcome with very low recidivism with just training alpha. So in 1974, we wrote a grant to NIH for alpha training in alcoholics. Now, over a decade before Peniston published the alpha theta protocol that became relatively well known for working with addiction. We basically only did alpha training. We didn't do alpha theta crossovers to try to get at deep psychological stuff that might be buried in the basement somewhere, unconscious, preconscious. We just basically taught them to be able to make background alpha. When you're low voltage fast, your alpha is so fast it's not synchronized. It's above 16 hertz. And obviously alpha at 16 isn't what you expect. 8 to 12, remember that answer if you take a test. But Niedermeyer says fast alpha is 11 to 16. At 16 hertz on up, it desynchronizes. So the desynchronized low voltage fast EEG in alcoholism, which has gene number 4 associated with it, which produces GABA receptors. You make so many receptors, you can't saturate them, you're over aroused. You need GABA, or you need alpha training, which will give you GABA. You can make your own GABA. You're quite capable of it, but you need some training. It's like a driver's training course for the brain. We don't come with a driver's training course manual. Nobody has the manual to know how to operate. We kind of stumble through life, figuring it out as we go, bumping into the limits and falling down a few times. And it's not an easy learning curve to necessarily learn how to operate your brain, but we all basically go through that.
Earn up to 16 CEU hours by attending Applied Neurosciences NeuroGuide Workshop December 10th and 11th in Madeira Beach, Florida. It's led by none other than Dr. Robert Thatcher himself. There are 2 ways you can attend, online or in person, with the link appliedneuroscience.com/attend-ng-workshops. And if you sign up now, you can join Dr. Robert Thatcher at his house for a pre-course get-together December 9th. It's going to be a blast. What a better way to enjoy winter by being in Madeira Beach, Florida, and earning up to 16 CEU hours. Sign up now at appliedneuroscience.com/attend-ng-workshops.
If you have neurofeedback, you have a driver's training course for the brain, and it helps you learn how to operate the brain systems in an objective way. Whether you're trying to become less overaroused as an alcoholic, or more open focus like a meditator, or more deeply able to fall asleep more readily. I mean, there's lots of ways to end up applying these trainings. But what we basically need to do is pay attention to the learning curve and where you're starting. And a low voltage fast EEG with over arousal, like we saw in the alcoholics, if you train them to make alpha, they're like a different person. They don't have the angst and the twitchiness. They don't need to reach for something to give them GABA. They're making it already. They feel like they used to when they had 4 shots of alcohol. Now, that got them to where you might start, normal. Now, if it takes you 4 shots to be normal, that's a slippery slope from there, isn't it? 2 more shots, and then you start to slow a little bit like most people would on the first 2 shots, much less 4. So, and you can't walk down the street sipping on a beer all day to kind of titrate your level. First of all, you smell like a brewery, and not everybody is going to like that. There's some people that are offended by people consuming alcohol while they're walking to school. You might see that in historic Germany, where the water wasn't drinkable and beer or wine was what you could consume safely. But nowadays, it doesn't really pass for normal behavior anymore. So you can't titrate your GABA by sipping on a beer all day. And people aren't really that good at holding the level properly either. It's tempting to have another beer and get a little more giddy and a little less aroused. But you get sloppy at some point there. So
it's got to get processed, right?
Yeah. But if you can learn how to make your own alpha, you don't need to be dependent on something outside. Yeah. And, being the captain of your own ship without having to be dependent on something ends up being a very good thing psychologically in and of itself. Knowing that you have control over something, anything in this life ends up being beneficial. And teaching somebody to be able to control their own brain, if you go to the doctor and you ask, can I control my brain? They'll say, oh, I'm sorry, dearie. It's part of your autonomic nervous system. Pat on the head, silly person. It's beyond your control. Well, who do you think is controlling it? Do we have strings going up? Is there a master puppeteer controlling us from afar? No, that's silly. We're our own controller. We may not be in control. We may not know what we're doing yet, but with a little driver's training course of neurofeedback, you can control the brain. We taught people who didn't have alpha how to make alpha. But at the end of the training, we always wanted to prove to them that they had control of it. So we would tell them, okay, now turn it off. Well, I'm sorry. I just learned how to make this stuff. It's the best thing I've had since sliced bread. In fact, it's like an order of magnitude better than sliced bread. This is like the best I've felt in decades. And you're telling me to go back the way I was? Are you crazy? Well, I'm crazy. I'll admit that. But I want you to turn it back off so I can show you that you can turn it on and off whenever you damn well please. And the patients needed to do that for us to consider their training done. You can't just accidentally stumble into the right state. You have to be able to get there when you want. And if you wanted to, you need to be able to leave there and go back to being excessively focused. Sometimes you need to be focused. You can't just be open focus, spongiform, soaking it in. Sometimes you have to actually focus on something. So we would teach them how to make alpha pretty much for the first time in a long time for most of them. And they really loved it. It was a great state. It was like having 4 beers. The that tension that's in me all the time is now gone. So the experience of 4 shots of alcohol or learning how to make alpha if you're not making any. And now we tell them turn it off. We don't do on, off, on, off, on, off training. We only go at the end to demonstrate that they have total volitional control. So that was our technique. And it seemed to work really well. Again, these people left the state hospital. Nobody wants to be there. I mean, even the staff, most of them didn't want to be there, but it's a nasty place. Yeah, it's a psychiatric hospital, and some of the people there are crazy. Some of them are staff. So
Yeah.
you've got people screaming, um, uh, psychotic people that are fighting with demons that you can't see, and it's chaos, and it's not a pleasant place to be. So if you can leave and stay out, you do. If you can't stay out because you're drinking again and they throw you back in the slammer, and the people in your town realize, oh, he's just a drunk, send him to the state hospital for treatment. So the people we sent out with the ability to make their own alpha, they didn't come back. If you could avoid coming back, you did avoid coming back. And if you can make your own alpha and avoid overconsumption, you're basically okay at that point. Now, we actually have worked with addiction, and let me jump through to the phenotype addiction. So again, this is a case series. It's not a control study. There's no control group. Um, we were basically looking to see what kind of phenotypes did we see in the clinical population that were in an addiction treatment program. And we wanted to characterize the effect of therapy that was based on the phenotype model, as opposed to a standard alpha theta style approach for people that had addiction. So you don't need the stats. I mean, it's a horrible circumstance. It costs us a small fortune. If you spend money on therapy, you save a lot of money for the society. There's a great ratio of what you spend and what you save. So there's actually a template for judging whether something is efficacious or not. When Don Moss was president of AAPB and I was president of ISNR, we decided that we had to work together to come up with these guidelines. We didn't want 2 separate guidelines for the field. We wanted to have a unified voice for the field. So we came up with this group and turned them loose to come up with the guidelines to identify when you could claim something to be effective. And there were people claiming effectiveness for things that really didn't have much evidence for it. So we needed some standards. So the efficacy standards, probably efficacious for the Peniston and the Scott protocol. Peniston protocol had some training before alpha theta. They did temperature training or electrodermal training, and then alpha, and then theta, alpha theta. The Scott protocol basically realized that, if somebody's got an alpha problem like ADD or depression, before you do the alpha theta training, you need to fix the alpha or theta deviation. Either suppress training or beta training or SMR training, some pre-treatment to fix the alpha or theta problem that was in excess of it before you just jump into training alpha or theta. So Bill and Cora Scott's protocol also got probably efficacious. So we basically looked at the phenotypes, and we found that there's 2 clusters. 2/3 of the 30 people had overarousal as their drive mechanism towards their alcoholism. They were overaroused. Fast alpha, low voltage fast EEG, beta spindles, the overarousal. And the other 1/3 of the addiction had a cingulate problem, not alpha theta at the back of the head, but anterior cingulate. They had an obsessive compulsive drive towards their addiction. So overarousal, low voltage fast EEG, they got SMR training because they need to get a pre-treatment to get a little something rhythmic, and then alpha theta. This is what the phenotype model said. If you had this pattern, you got these treatments. The fast alpha goes straight into alpha theta training. Beta spindles got SMR and then alpha theta. So overarousal people all got alpha theta, not because they were addicted, but because they were overaroused. The anterior cingulate people either had alpha or slow or beta at the anterior cingulate. They needed a different approach. And basically, we did suppression at the anterior cingulate, not alpha theta training. This is a low voltage fast EEG from 8 to 12 Hertz, Z scores. This is work from Martijn Arns. He caught a lecture, and I said, you give some alcohol to a low voltage fast person, and eventually they'll end up making alpha. Well, trust but verify, just because I said it, it doesn't mean you should believe it. For God's sakes, don't be a blind follower. Don't just suck down whatever somebody tosses out. Be critical and think about it. So here's time 0, no alcohol, no alpha. Time 1, 2 shots of alcohol. They were in the Netherlands and they used vodka. Yuri did the same thing using cognac in St. Petersburg. Don't they know archetypes? So oh well. Now you're 2 shots of alcohol. You're starting to get a little bit of alpha, but it's not really a lot. And here's 4 shots of alcohol. Now you're talking. We've got power in the alpha band. 6 shots of alcohol. Well, you're starting to lose the upper frequencies, and you're starting to develop the 7, 8 end of the spectra here. So you're starting to slow. And so they get 4 shots of alcohol that are like a normal person is when they start. So, it's time to think about making it for yourself instead of having to consume it. So, cingulate findings, there's stuff at the anterior cingulate. This is a low voltage fast EEG. Z scores, again, low voltage, negative Z scores, blue. And if you get up into the beta frequencies that start to be normal-ish, there's no excess anywhere. This is basically deficits with a little bit of halfway normal stuff when you get up into the fast frequencies. So this is a low voltage fast EEG. And again, classic alcoholism biomarker, but it's also present in people who don't touch a drop of alcohol. You might have a family history of alcoholism, have been put off by it. I mean, beatings from dad don't really make you feel like drinking, So, you could be a teetotaler because you saw the effects on relatives, and you've got the brain pattern for it. You just don't do the alcohol consumption, so you're a little tightly wrapped. And learning how to make alpha will end up helping tremendously for that. This is basically Z scores, and you can see fast alpha in this case. This is 12 and 13 Hertz for the background alpha. Again, Z scores. There's an excess of 11, 12, 13, especially 12, 13. Start to fade out at 14. So super fast alpha, but it's not to the point of being desynchronized. It's just very fast alpha. Beta spindles, excess, very fast activity up in the beta frequency bands. So we had an overall therapeutic approach. They added neurofeedback in to a classic 12-step program with group counseling, individual counseling, occupational therapy, whatever normal stuff. Now, Royal College of Medicine, John Griselier, found that if you do alpha theta training, it reduces the overarousal patterns. It decreases beta, slows things down, gets rid of the overarousal. And Dr. Conjito, who was originally the fellow who showed that Loretta training could work in Lubar's lab, they brought the Retta software back from Zurich and put it into a way that it could be used other than having to know how to run Pascal as a software package. So they brought it back from Zurich to be able to be used. And they basically found that treating the anterior cingulate ended up helping with cingulate-related behaviors like OCD. So what we found is normalizing the anterior cingulate helped with any obsessive compulsive drive, and alpha theta train helped with any over-arousal related drives. And what happened neurocognitively? Well, this is Wilcox-Johnson 3, which you can do at 1 year follow-up. And at 1 year follow-up, we found a 21-point jump in IQ. Well, it's GIA. It's the equivalent of IQ. So, and these are standard scores, normal to rather superior performance. And it's not like two people that were bad, got up into the curve. The mean of the curve was 99, and the mean of the curve now is 120. So it's not just a couple of outliers. This was a shift of the entire group. Same thing, thinking ability. Short-term memory, it can't be processed automatically, normal to superior. Again, the mean shifted. It's not just it was a skewed distribution, and now it's not as skewed, but the average went way up. Cognitive efficiency, pre is normal-ish, post is superior-ish, and again, the entire group ended up improving. Audiovisual learning ability, pre is not quite normal, post is better than normal, but it's not quite in the 120 range. Delayed recall, this is not a good score at all. The starting point was such that you could probably tell them, I'm going to stick this $10 bill under the keyboard on my computer. At the end of a half hour, if you remember it, you can have it. You'd probably keep that $10 bill with scores like this. Now, if they went to normal, you're going to lose your $10 bill at that point. Working memory, normal to superior. Every single neurocognitive piece improved. None of them got worse. When you make the brain work better, it works better. Surprise. And they were all clean and sober at 1 year, all 30. Now, it's hard to even get anybody to believe that you got 100% people clean and sober at the end of 1 year in alcoholism or drug treatment. It's really hard to get anybody to believe that. The normal recidivism rate is gigantic. In the state hospital, there was about a 90% of the people would come back around. And state hospitals aren't the best treatment program necessarily. There's expensive treatment programs that treat you really well in Malibu, for a whole chunk of dough. That you get massages and all sorts of really fabulous treatment. But even there, the recidivism is really quite high. About half of them, sometimes even more than half, will end up returning. It takes multiple trials usually for people in 12-step programs to end up succeeding to stay clean and sober.
Where does this fall, AJ, for like AA? Does this like fall on their radar where they try to send people to get help, or they can't afford it, or they don't know about it? Or I'm just trying to think, like Betty Ford, we're talking in the 70s when you got in the game, and she made addiction to the helped get it to the forefront. I was just wondering how do we get this? I know we need it everywhere, but for addictions, the information you're presenting, it looks very positive. Yeah. Why aren't they catching on?
Same reason nothing catches on. It takes time. If today all the med schools were teaching this as the standard of practice that you should be doing, it would still take another decade. I mean, you come out of school as a rookie, junior practitioner, you sign into a group because very few people hang a shingle for themselves anymore. So you go into a group, you're a junior partner, you can't set up a treatment program. You can fit into the one they have. And, 4 or 5 years later, they start to trust you well enough and you can bring something new in. So, 5 years if you're lucky, 10 years if you're not. If that were being trained now in the schools, well, it's not being trained now in the schools. So it's, the information is out there. Alpha theta training works well with addiction. But if you use the phenotype model, alpha theta training is only good for 2/3. The 1/3 that it doesn't work with, you can identify if you look at the EEG ahead of time. And the phenotypes basically predict what therapy you need for the group that you're in, regardless of the diagnosis. So DSM doesn't work to predict therapy. The phenotype patterns work really almost spooky how well they work. My business partner was Curtis Kripe, and Crossroads Institute was his. He had, I think it was 11 clinics in the United States that worked with addiction. Now, he had a major car accident that almost killed him, and that kind of put an end to the clinics. I mean, if you can't operate the clinics, they don't really stick around. So, but we had good success, and 30 out of 30. Curtis Kripe was my business partner on this, and he wanted me to look at the data earlier. And I said, well, I don't want to look at any data until you get at least 30 people. And that's why we had an N of 30. I wouldn't look at it with 10 or 15 because group stats, and group stats work well with 30 people in the group. And we're looking at subgroups, So if you don't have at least 30, you can't even start to talk about it. And so, it worked well enough to show us that there were a couple of major drive mechanisms that were separate for the two groups. And they responded differentially to the training. So I'd like to be able to wave a magic wand and have it, suddenly appear in all the alcoholism drug treatment programs and school settings and, on and on and on as to the spots that could productively utilize learning how to operate your brain. So you'd think schools would be like interested in teaching people how to operate their brain, but it's a foreign approach to traditional teaching. So,
well, if you can't get the kids to learn how to do personal finance, I don't know how we're going to get them to figure out their brain.
Yeah. So, imagine a school with a playroom for the very young kids in the school. Now, there's a whack-a-mole game that's like a go-no-go task. A little deal pop up here, pop up there, and you got to whack them. Well, do you have omission errors where they pop up and you don't whack them? Do you have commission errors where you whack them and they're not really popped up? What's your reaction time? What's the variability? You could get a CPT task equivalent of a TOVA or an IVA with a game, a whack-a-mole game for kids. And if you really do bad on the whack-a-mole game, you could go over there and play that brain game for a while. And after you're done playing that brain game, you can come back here and see if you can score higher, more like the regular, the little Johnny's got a better score than you've got. So if you want to get a better score, go play that game, then come back and play the whack-a-mole game again. You could actually treat the person's ADD, impulsivity or hyperactivity or inattention without diagnosis. We're just playing games here, and the school doesn't want to diagnose anybody because if you diagnose somebody as ADD, now you got to provide extra services and whatnot. So, but if there's a game room for the kindergarten and preschool and first and second graders to go play in, you can have non-diagnostic games that the score, if you want to score better, you can go over and play in that game and then come back and play in this game. So there are, and the kids that are overactive and have impulsivity, hyperactivity, you can have this breathing game over here, and you could do HRV basically to teach somebody to wind it down a bit. So the game room in a school, you've got a playground out there, but there's a game room too, and kids like to play whack-a-mole games. And if you can hook up a cheap little dry sensor headset, and they can end up learning how to control their brain a little bit, it's still just a game. There's no DSM associated with any of this.
For the teachers too.
Yeah. Yeah. Well, anybody and everybody should really have a shot at learning how to operate their brain. It's the fine-tuning, high performance end of things if you're already performing. And if you're pathologically performing, the same treatment is there for you in your phenotype. And even if you're normal, your phenotype predicts the kind of training that will end up optimizing. So I would like to see EEG evaluations, but if you really have bad performance on things and the EEG game goes really bad for you and everything, it's time to pluck the student out of there and send them to an evaluation. Yeah. And epileptiform content can be identified on occasion, and you don't want to diagnose them as epileptic, but you want to end up having it evaluated and treated appropriately by somebody who's a professional. It's not a teacher's job to diagnose the epileptiform content and decide what kind of treatment needs to be done. But most of the people would be evaluated with the games and treated with the games, independent of any DSM being evaluated. It's a simple training. You don't want to diagnose them as having something wrong, because little Johnny and little Susie, they don't want to end up being classified as different than the rest of the little Johnnies and Susies. So anyway, schools are an ideal location for neurofeedback to get things going early in life. And like the chaos theory says, a little change early gives you a giant change later. A butterfly flapping a wing in the Brazil ends up creating a hurricane or a typhoon somewhere else. So what we basically have here is the ability to intervene early without the pejorative of a diagnosis. And the phenotypes that are seen in normals and clinical people. It's just a matter of proportion. You still have the same spots, but the leopard behaves better. So you don't change your spots.
Jay, you really worked overtime for our part 2. Thank you for this whole series on alpha in a can. Make your own alpha.
We'll talk a little bit about beta and theta and sigma and gamma and all of that.
The NeuroNoodle podcast is supported by listeners and viewers just like you. And a special thanks to our gold and silver supporters. Earn up to 16 CEU hours by attending Applied Neurosciences NeuroGuide Workshop December 10th and 11th in Madeira Beach, Florida. It's led by none other than Dr. Robert Thatcher himself. There are 2 ways you can attend, online or in person, with the link appliedneuroscience.com/attend-ng-workshops. And if you sign up now, you can join Dr. Robert Thatcher at his house for a pre-course get-together December 9th. It's going to be a blast. What a better way to enjoy winter by being in Madeira Beach, Florida, and earning up to 16 CEU hours. Sign up now at appliedneuroscience.com/attend-ng-workshops. Mindmedia.com. Get the latest EEG and neurofeedback technology from mindmedia.com. Their semi-dry sensor cap is a wonder to see, and their EEG amplifiers have been trusted in the field for decades. Their neurofeedback and qeeg courses will get you up to speed in no time. Visit mindmedia.com.